To those affected by mitochondrial disorders, UMDF is here for you. Since 1996, we've worked to provide support, fund research, and create awareness.
Our mission is to promote research for cures and treatments of these diseases and to give support to affected families.
We want future generations to grow up in a world without mitochondrial disease.
I'm playing for the United Mitochondrial Disease Foundation.
Look at that. Nice check for you.
Over the years, our community has grown and our message has sparked a movement.
Hey everybody, it's Maya Mialik. Have you ever heard of mitochondrial disease?
Together, we've been able to make a difference for patient families around the world. Today, we are helping thousands of people navigate their mitochondrial disease journey. We're here, listening and providing support. We're here, educating and connecting patients and healthcare providers. We're here, finding and funding the best cutting-edge research. We will not rest until we find a cure. Join the movement at umdf.org.
Hello, everyone. Thanks for joining us for our latest Ask the Mito Doc webcast. Tonight's topic is mitochondrial disease and siblings. Got a great panel tonight of experts. Dr. Michio Hirano is with us from Columbia University in New York City. Dr. Hirano will present information tonight about the genetics of mitochondrial disease between siblings and families. Joining us from Las Vegas, Nevada is genetics counselor Devin Schumann. Devin not only is an affected patient, but her sibling is affected as well. And also joining us later will be UMDF ambassador Isabel Taylor. Isabel is a medical student at the University of Utah School of Medicine, and she will discuss her experiences as a sibling to a brother who had mitochondrial disease. But before we hear from our panel, we have some housekeeping items for you tonight. We have muted the lines, so if during this webcast you have a question, please use the Q&A button to type in your question so that we can get answers. Also, we ask that you keep your questions focused on the topic of the webcast. We really can't take questions that aren't connected to tonight's topic on mitochondrial disease in siblings. Also, please note the information about the closed caption service that we have available and how to turn that off if you don't want to see it. Our Ask the Mito Doc webcasts are made possible through the generosity of these sponsors. So we ask that you join us in thanking them for their support. 2021 is also UMDF's silver anniversary, and throughout this year, we're going to have special memories on our website and also our social media channels. So stay with us and check out our Facebook page and see some of the memories that we have. Also, we want to tell you about updates we've made to our coronavirus web page. It's a resource page, and it is on our resource area, specifically talking about everything that we have learned about COVID-19 and the mitochondrial disease patient community up until this point. Also, make sure you check out MitoU. This is a fantastic resource for patient families in our scientific and medical community. It will provide you with helpful information on diagnosis, treatments, and we continually update informational videos for your viewing. And also we archive all of these Ask the Mito Doc webcasts there, so you can go back and watch previous episodes. As you might expect, out of an abundance of caution for our patient families, scientists, and clinicians, Mitochondrial Medicine 2021 will again be virtual this year. We will begin on June the 24th and end on June the 26th. We invite you to check out the UMDF Symposium webpage for updates, schedules, and registration is now open. You can learn how to register on that page as well. Also, we want to tell you about another important program UMDF has provided for over 25 years, and that is patient support. We can connect you to one of our 90+ ambassadors around the country or through one of the hundreds of support meetings we hold throughout the year. So please, if you need support, reach out to us. You can call us at 888-900-6486. And our Energy for Life walkathons, Walk Your Way, getting ready. They are going to launch very soon. So find a walk location near you. You can go to energyforlifewalk.org. Now, looking ahead next month, Our topic for Ask the Mito Doc in May will be drug development for mitochondrial disease. So you'll want to mark your calendars for May the 11th at 7:30 p.m. and watch your email and social media for ways to register and to submit your questions. But for now, let's get started with this edition of Ask the Mito Doc panel. Thank you all for your generosity of time tonight. And we will begin with Dr. Michio Harano.
Okay, thank you, Cliff. And I'm going to try to share my screen. Can you hear me? And hopefully you can see my screen.
We can hear and see your screen, yes.
Okay, great. So I'm going to give you a little bit of background, a little genetics. And actually, since we have a genetic counselor, we have an expert here who could give some comments as well. And just so that we kind of set the stage for understanding how mitochondrial diseases are inherited, and they can be inherited in multiple fashions. And that affects the way siblings may be affected or unaffected in a family. And they could be, siblings could be affected with the same mutation, but have completely different clinical manifestations. So understanding some of the genetics can help explain some of this. So, okay, here are my financial disclosures. They're not related to tonight's presentation. And so mitochondrial diseases 101. So we all learned about mitochondria in high school, about how these are the powerhouses of the cells, these tiny kidney bean shaped structures that look rather static in these pictures, like this electron micrograph showing mitochondria from a dog heart. But they're very dynamic organelles. They move around in the cell. They track along these microtubular rails, and they move up and down. They sometimes merge, they fuse, and then they divide. So they're very active. And of course, they produce the energy that's necessary for life. And this is a picture of a muscle biopsy. And in the old days, we used to do a lot of these. We do less of them now because of genetic testing. But you can see here that this is a special stain where the fibers look bluish green. And these fibers are the classic ragged red fibers that we see in many mitochondrial diseases. And that's because they're full of mitochondria here along the edge of the muscle fiber. This is a slice of muscle, like a really thinly sliced, like prosciutto. Oops, sorry, going back. And so we can see that when mitochondria are dysfunctional under the microscope. And sometimes we can use these special stains for the mitochondrial enzymes complexes. This is complex 2 and complex 4. And you can see these are actually two sections of muscle sliced right next to each other, one slice after another. So they're the same fiber. And you can see here that this fiber it looks normal, this bluish color, but it's lacking in this other enzyme complex 4 because there's a mitochondrial problem here. And this fiber, this is lacking complex 4, has too much complex 2. And that's because it's a ragged blue fiber, very much like the ragged red fiber. So it's a sick muscle fiber which has proliferated many mitochondria to compensate. And this is a picture of a patient with a classic sign of mitochondrial disease. She has droopy eyelids, ptosis, that many patients with mitochondrial disease have. And you can see that she's using her forehead muscle, the frontalis muscle, to pull up her eyebrows and lift up her eyelids to compensate. So these are some images of mitochondria, mitochondrial disease that just sort of to set the stage for some of the things we're going to talk about tonight. And as you all know, when mitochondria are affected by these mitochondrial diseases, typically we don't make enough ATP energy, and that affects all of these different parts of the body, but particularly brain and muscle. So these organs require lots of energy, and so patients often have brain and muscle problems, not just weakness, but exercise intolerance and a lot of fatigue. So, but as many of you know, these diseases can affect many organs in the body, the heart, the eye muscles around the eyes, as we described before, causing drooping of the eyelids and inability to move the eyes. And liver can be involved, kidney. Sometimes there are endocrinological problems like diabetes. Rarely the blood can be affected, and often hearing loss is a common feature, and gastrointestinal problems we're seeing more and more frequently. So these are very complex disorders, as you know. So I'm going to set the stage for understanding some of how siblings can be affected in the same way or different ways in the same family with the same genetic problem. And so I'm going back to the 1800s, when this fellow, Gregor Mendel, was studying garden peas as a monk. He was an Augustinian monk in a place called Brno, which is now in the Czech Republic. And he was really a giant in the field of genetics, because he discovered the inheritance pattern just by studying peas, as we probably learned in high school about wrinkled and smooth peas. Well, that's obviously relevant not just to peas, but to humans as well. He discovered different kinds of inheritance pattern. So this is a family, and many of you may not be familiar with this kind of a figure, but these squares and circles represent men, the squares, and women in circles. And here we're showing that the people who are in the filled circles, the white circles, have a disease or a condition. Oops. And you can see here, this woman who's let's call her the grandmother, has passed on this condition and this mutation to 2 of her 4 kids, a son and a daughter. And this son has passed it on to 2 of his 4 kids. So I'm going to ask well, maybe I can't ask this question, but this is a particular inheritance pattern. And it's maybe if someone wants to give their guess what kind of inheritance pattern this is in the Q&A section, we're happy to acknowledge whoever gets the answer right. But a clue here is that there's male-to-male transmission. And I'm sure Devin is squirming in her chair, ready to say the answer. No? Okay.
Yeah, I know what it is. I just didn't want to break it because other people were answering.
Oh, they were. Okay, I don't see the Q&A.
Yeah,
One person guessed
Okay.
could be maternal.
Okay, well, that's why I pointed out the male-to-male transmission. So it can't be maternal if there's a man here who's passing it on to another person. Oops, sorry. Actually, I don't know how to see the Q&A part, so.
The next guess was autosomal dominant from Lynn.
Oh, great. So Lynn is the winner. She is absolutely right. This is an autosomal dominant inheritance pattern. And so when you have a dominant trait, it affects each generation. And if a person has a dominant trait, they have a 50-50 chance of passing it on to each child. So that's why this woman has 2 out of her 4 kids are affected. And similarly, this man has 2 out of his 4 children who are affected. And you'll see this side of the family doesn't have that trait and doesn't have the disease. So it all is transmitted through this paternal grandmother. So that's an autosomal dominant inheritance pattern. Okay, great. So if that's the case, then usually with autosomal dominant diseases, the onset is usually later, because they may be completely normal until they're adults and may not know that they have the disease, and they pass it on before they even realize that they have a condition. And then it's transmitted to their children, and they may not develop symptoms until they're adults as well. It's a typical presentation, or they may have mild symptoms early in adulthood pass it on. And usually in autosomal dominant conditions, most of the people are affected more or less in the same way, although there can be slight differences in severity. Okay, so here's another family. And this is a large family. And these two people in the bottom generation are affected, a man and a woman. But nobody else in the prior generation is affected. Now, you'll see here that there's this double line here between this man and the woman. That means they're related because, oops, they have common grandparents. So this is what's called consanguinity. They're related by blood, and so they presume. So so maybe before I go further, I can ask if anyone can guess what kind of inheritance pattern this might be.
Hannah says recessive.
All right, so Hannah is the winner this time. Great. So yes, so this is a recessive pattern. So these parents each carry a mutation that presumably was present in one of these grandparents and was transmitted through the parents and then to these people who each carried a mutation. And in order to have a recessive disease, you have to have two mutations, one from the mom, one from the dad. And so that happens in about 1 out of 4 children. So that's why 2 out of the 8 people here are affected with the disease. And that's the autosomal recessive inheritance pattern. And in this situation, often these recessive diseases can present in early childhood. The parents are totally unaware that they carry a mutation in most cases, and then they discovered in their oldest child who's affected that the child is affected with a genetic condition, and through genetic testing we might find the mutation that's the cause of this. And we've seen that in our North American Mitochondrial Disease Consortium, NAMDAC. We have a registry, and we see that there are a lot of patients in our registry with autosomal recessive disease who have early childhood onset disease. So as I said, often these autosomal recessive diseases present early in childhood, and so these two siblings are affected, and usually they're affected to similar degrees, but sometimes there's some variations, but typically they're all equally or pretty similarly affected. But the majority of these siblings are unaffected. Okay, because each sibling has only a 1 in 4 chance of inheriting the disease. Any questions so far?
Not so, not yet.
Okay. Sorry, not yet. Okay. Devin, you want to make any comments about recessive inheritance?
Remember this slide for when I talk later.
Okay, great. But you don't have to have consanguineous parents to have a recessive disease. We all carry variants which are mutations, and if it could just happen that 2 people who are unrelated each carry a mutation, and they might be different mutations in the same gene, and just by chance the 2 parents happen to carry mutations in the same gene and then pass it on to their children. So that can also happen. All right, so Gregor Mendel was great in defining these dominant and recessive forms of inheritance, but then there are these other non-Mendelian forms of inheritance. And okay, so how about this one? Now in this case, well, there's a clue here. You'll see that there are 3 filled figures. These are all males. And let's see, 1, 2, 3, in 3 different generations. So this is odd. Is that by chance that these men were that only men were affected? Or was there something else here, that some other factor that played a role in why the men were affected and women were spared? Now these dots actually are a clue. Anybody want to guess what kind of inheritance pattern this is?
We have a couple people all saying X-linked.
X-linked, you're right. And specifically X-linked recessive, meaning that these women who have these dots are not affected. They don't show any signs of the mutation, but they carry the mutation. The dot means that here it shows that they're carrying the mutation. So this woman has the same mutation as her son. She passed it on. However, because the son has only one X chromosome, he's affected. He has an X and a Y, whereas the mother has two X chromosomes, one of which has a normal gene and the other one has a mutation. So this woman passed on, unfortunately, the mutation to her son, who then is affected. Probably one of the best known X-linked diseases is Duchenne muscular dystrophy, but there are many other X-linked disorders, recessive disorders, including some rare mitochondrial diseases that are X-linked recessive. And so you would expect it to affect males only, or sometimes we see some diseases where the men are affected more severely than women. So it may be X-linked dominant, but just where the men are just more severely affected because women have two X chromosomes, one of which protects them. So you can see here, this woman passes on her mutation to her daughter who doesn't have a disease because she's a carrier, passes it on to her daughter. And this daughter then has a son who's unfortunately inherited the mutation and has the disease. But you see that several women here carry the mutation. Many times they don't even know they're carrying it. They have absolutely no symptoms of the mutation because they have two X chromosomes, one of which has the normal gene and protects them. Okay, so that's in these sorts of families, we'll see that only men are affected and women are spared of the disease, although the women can carry it. And that's X-linked recessive. I gave away the punchline here. Sorry. But this is an example of mitochondrial or maternal inheritance. And how does it look similar in that there are women who pass on the disease, but you'll see that both men and women are affected. And you also see that the men who are affected never pass on the disease because the mitochondria and mitochondrial DNA is transmitted exclusively through mothers. Only mothers have the power to pass on their mitochondrial genome. So that's why you see this pattern of inheritance where only women transmit it, but both men and women can be affected. Now, the slides were reversed. I'm sorry about that. Okay, so I'm going to just give you an example of a maternally inherited mitochondrial disease to kind of illustrate a couple of points about this inheritance pattern, because it's unique to mitochondrial disease. No other diseases other than mitochondrial DNA diseases are maternally inherited. So this is one of the classic syndromes called mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. It's a long name. We know it better as MELAS. And it was first described by some of my colleagues at Columbia back in 1984. And it's a disease that's one of the most common mitochondrial DNA diseases. Unfortunately, it causes these strokes or stroke-like episodes. They're not classic strokes because they're not due to occlusion of blood vessels. They're not due to clots in the blood vessels of the brain, at least not the large blood vessels. Maybe the small vessels are involved, but so they don't conform to what we call vascular territories. So they're atypical strokes, and they're also atypical because they frequently affect young people, typically before age 40. Sometimes they occur later, but it's very these are very unusual in the way they appear on MRI and CT scans and the way they affect young people. So this particular mutation was identified as one of the first mitochondrial DNA mutations identified in the tRNA leucine gene. You don't need to know the specifics of this, but it's the 3243 mutation. And it's one of the most common mitochondrial DNA mutations we see in our NAMDAC registry. But when we encounter a family with this kind of a mutation, what we often see is not the typical maternal inheritance that I showed you earlier, where all of the women who carry the mutation have a disease and then they pass it on to all their children. In fact, what we often see is that there's one person in the family who's very severely affected, as in this case, this young girl that we would call the proband. She was the one who really brought attention to this condition in the family. She had some difficulty climbing stairs when she was 2, and by the time she was 5, she was short and thin because this disease was stunting her growth. And she had something called a Gower sign. In order to get up from the floor, from a seated position on the floor, she had to put her hands on her knees to push herself up because she had weakness of her proximal muscles in her back. So at age 5.5, after running around doing some strenuous exercise, she lost consciousness for half an hour, and then she had these recurrent bouts of vision loss, which were a little bit puzzling initially, and they were found to be due to stroke-like episodes. And at age 6, after another bout of exercise, she had right body tingling and then transient blindness. She couldn't see at all. And then she developed a seizure. So she was having these events which, in retrospect, are stroke-like episodes. And she was treated with medications, but she still had seizures. And then she developed heart problems. As I explained earlier, mitochondrial diseases often affect the muscles, including skeletal and heart muscles. So this was unfortunately very devastating for her. She became deaf and lost her cognitive abilities due to strokes, and she passed away of a heart failure. So she was very severely affected. And her brother, who had was short and had some cognitive issues, but was otherwise relatively healthy, as were, and her 2 siblings, her 2 sisters. One was about in her early 20s, the other one was about 13 at that time, were completely healthy. And the mom was as well. So why is it they have the same mitochondrial DNA, but it actually differs in that this person who has no symptoms at all has 15% mutation in the blood. This person who's actually more affected has an even lower percentage, and this person who's also healthy had a very high percentage, but it doesn't, and the mom even had a higher percentage. We don't know what happened in this proband in the first child because she passed away before she could be tested. But we see that these people have different levels of mutation, and that's why, although they all have this MELOS 3243 mutation, they have different levels of this mutation in different parts of their body, and presumably this poor child had a high level in her brain and heart muscle in particular, which led to her MELOS and heart problems. And this child, the boy who has some cognitive issue, presumably has a higher level in his brain, whereas the other 2 unaffected siblings are relatively healthy and presumably have lower levels of the same mutation. So that's why with mitochondrial DNA diseases, you can have the same mutation present in all of the people in the maternal lineage, and yet some people are severely affected, some can be completely asymptomatic, and some can be moderately or even very severely affected, but not as severely as the proband, the one who really brings attention to the disease in the family. So I hope that concept is clear. If there are any questions about that, please feel free to ask. But I think this is something that is unique to mitochondrial diseases. It's the maternal inheritance of these mitochondrial DNA mutations. And I think is very important for families to understand why that some people in a family may be unaffected and others are severely affected with the same mitochondrial DNA mutation. Okay. So I'm finished with my formal presentation.
Okay.
So
we will take questions in a little bit, but first let's go to Devin Schumann and her presentation.
okay.
All right, can you guys see my screen okay?
We do.
All right, I'm also turning on my little camera just because I tend to talk with my hands. So my name is Devin. I have mitochondrial disease, but I am also a genetic counselor, and I have a brother with Mito. So this was a wonderful melding of the worlds for me. Now, in terms of where to start, I always think it never hurts to get pictures of what we were like when we were little. So this is me and my brother. He's 2 years older than me. And people used to think that we were twins because we were attached at the hip and we looked a lot alike. As time has grown up, we don't quite look like twins. We still look like each other, but we're still really good friends. We never would have known then what diagnosis we have. We weren't diagnosed till we were teenagers. And flash back to that autosomal recessive page that Dr. Hirano talked about, there was a 1 in 16 chance that me and my brother would both have Mito. So, right, autosomal recessive inheritance, we have 2 copies of every gene in our body. Both of our parents carried a change on the same gene. They both flipped heads or tails, passed down the not working copy. So when I work in clinic, most of my patients call that unlucky when they've got 2 kids with it. Honestly, I think it's kind of the opposite. For me and my brother, I'm glad that we have each other, in part because I don't think I would have been diagnosed without him being diagnosed first. And in part because it means that when we have new symptoms or new things that we're worried about, we have someone that we can Skype. So we were Skyping for like 3 hours this morning, just hanging out. And I'm glad that I have him for that reason. Now, I am also a genetic counselor. The way I joke about it is I was already Googling all of this anyways, so I might as well get paid for it. And I run a teen and young adult group. So some people know me off of Facebook. I had to throw in a picture from when the UMDF brought us Santa Claus for our Christmas chat, and we all took a picture. I include a slide later where I polled the audience because I think these siblings, these people, they know it better than any research paper you can find on the topic anyways. So what is a sibling? I'm personally a huge proponent for colorful diagrams. And I think it's important to realize there's so many different types of siblings we're talking about today. We have unaffected siblings, whether that means we don't know if you'll be affected in the future, whether that means you don't have symptoms, you could be a carrier. Even that is not a black or white category. Then a lot of people talk about how some siblings can be more affected than others. Again, there's a crossover. How do you define worth? On our calls with the teams, we all debate that all the time, right? Someone shares a new symptom and everyone's like, I can't believe you deal with that. But it's all going in a circle. I might view a feeding tube as a significant involvement. Someone else, their feeding tube's normal. They view something I have as a significant involvement. We're all different in how we interpret that. And I'd say the genetic counselor in me is that section in the middle. It's all just a giant pile of emotions, right? I mean, we're all along for the ride, and there's not one right way to think about this or feel about it. Every emotion is valid. And that was one of the first things they brought up when I said, what would you want people to know if we did a talk on Mito siblings? Everyone copes differently. Still, how to make people's emotions feel valid, not feel the siblings who are less affected or unaffected feel left out. A lot of people were talking about, well, what I really want them to know, I want parents to know, can you help my siblings talk to their friends about it? And can we have those conversations about what would help me most in a crash? That was the question that most said when they asked their unaffected sibling. What would you want answered? It was, how can I help my friend? How can I help my sibling? So I'd say that's a conversation families should have, but they also got right into the nitty gritty of it, right? Google is scary. Please have the tough conversations so that people aren't Googling it and finding it that way. Like, talk about what you see there. The fact that you're still a sibling if your loved one passed away, and coping with the grief as Mito develops, not just for those who have it, but for the siblings too, or people who are unaffected but are becoming affected. How do you have that conversation? Are you aware if maybe that sibling's worried every time they get a migraine that that is really Mito starting? Now, to sum it all up, one person put it really well. It was normalcy. That was the common theme when I asked, what about siblings? Everyone who was like, I love my brother and sister, I love my siblings, they did it right, quote unquote. It all came down to, they treated me normal. We fought, we teased, we got in fights, they would hog the TV. Like, that was the normalcy that people remembered the most out of all that other stuff that we spend so much time talking about. And I think when you do look up siblings online, you see a lot of super sibs or glass children concepts, and it's all focusing on the extra stuff. And honestly, siblings are like, I don't know if I want to be put on that pedestal. We want to be all normal, and the most we can do to have that and build that in, still have movie nights, even if you're in the hospital, that's what people really wanted, and acknowledging that. Now, I will say that the genetic counselor in me is all about resources. And I don't know if I'd considered in a long time what resources exist for the siblings who don't have symptoms. We're always so focused on, you're diagnosed with something, UMDF conference, the calls, all of this, but there's entire organizations just for the siblings who have it. And I think that's a really important thing to put out there. So I tried to make a list based off recommendations and ones I found, so that people can come back to this video and look them up later, because I think there's a lot of really good information on these sites. I included a couple screenshots just to show. They walk through different ages and different conversations and useful links and tips and tricks for school and friends. And I think there's a lot more there than you could probably ever get from a genetic counselor in a 1-hour appointment. So I think people have recognized that this used to be an unmet need that now organizations have stepped up for. So this is one out of the UK that someone sent me in particular saying, I love this group. I think they're really on top of it. These are all links that you can find on their website. But there's also books. And that was something that people also mentioned, was having a children's book that just has chronic illness in it or genetic conditions. It normalizes it in a way that's not formal, right? It's not a conversation, sit down. It can just be something on the shelf that makes it seem more normal to you. And I think the fact that organizations like Unique, that normally just make packets on different genetics to explain the symptoms to families, the fact that they made an entire packet just about supporting siblings is a good sign that we're moving in that direction of really supporting everyone. So I figured I can compile these. That Excel sheet was way too big to fit on the sheet, so I included a link there so people can go back and find it. I think there are a lot of cool new things out there that a lot of people don't think to take the time to go look for. And on that note, I was surprised to find there's actually 2 conferences coming up just for siblings of those with rare diseases. There's one that's actually this weekend, the one on the right, they're all virtual. And then the one on the left is in June. And it was a good, again, reminder that we focus on all of this stuff so much with the diagnosis itself, but there's a lot that goes around in the bubble surrounding the person who has the most symptoms. And there's actually a lot of really good resources out there now that probably didn't exist 5 or 10 years ago. So I was happily surprised. That's all I'm actually going to say, because I think it's really important to get to the question and answer part, but I wanted to compile this so people can go back and look if they ever need it. And if you have any genetics questions, you can throw them at me or find me on Facebook later and I can help with that too.
Okay, Devin, thanks so much. I want to bring in our third panelist, Isabel Taylor. Isabel, too, is a sibling who lost her brother Simon to mitochondrial disease. So, Isabel, I really would like you to talk a little bit about being a sibling to a patient and some of your experiences.
Yeah, Simon was really involved. Sorry, I'm probably gonna cry.
No, go ahead.
With everything that our family did. So he would come to my older brother's sport games, and he would come to my dance recitals. And pretty much everything that we did, he was involved in. My parents did a really good job making sure that he was part of everything that we did. So I think that that was really great growing up. I don't think my older brother, I ever felt like he was getting more attention or like there were any issues with things like that. I think my parents did a really good job.
And that's one of the questions that when you have a sibling who is not well, that sometimes they command all of the attention. But in most cases, that's not the case. Parents really try to work to even that out. Would that be what you'd say your experience was?
Yeah, definitely. And he needed different things than my older brother and I did, like a lot more medical attention and things like that. But I think that I was just kind of understood. My older brother and I needed more attention when it came to like schoolwork and extracurriculars and things like that. So it was just different.
Tell us about Simon. What kind of a person was he?
Simon was my best friend. He passed away 7 years ago when he was 13. He loved going outside and he loved, well, we think that he loved the color orange and fish and watching colorful things on TV. And hopefully he loved spending time with us too. It was a lot of fun growing up with him. I would dress him up in girl clothes and do all kinds of fun things with him.
Dr. Hirano, I want to bring you back in. Many family members wonder if their parents or sibling has a mitochondrial disease, that they or their children can be affected. What can you tell us a little bit about heredity? And what I mean by that is, let's suppose that a family member has just been diagnosed and I'm the brother of the family member. What should I be concerned with, even though I'm not exhibiting any symptoms?
Yeah, so I think this is why genetics is so important to define what is the cause of that affected person's disease. And based on that, we can know whether it's a autosomal dominant or recessive condition. And then we turn to people like Devin and counsel people and explain to the families how that disease is transmitted and the risk to each individual in the family. So, so maybe I'll turn it over to Devin because this is really her specialty.
I mean, honestly, I think exactly what you said is right? Like, that's why I think a lot of us push genetics so much, is sometimes that is the only way to give families a more concrete answer to that question. Otherwise, what normally happens is people sit down in front of me and they go, I'm worried about this. I think it might be called this. I'm not sure. And he's the only one with it. And we just play a game of what ifs, which is not the most reassuring game to play. But if it was this inheritance, this is your chance. If it was this, then it's that. And for some conditions, if it's something very common, which usually Mito isn't on panels, that's carrier screening that you can give to just anyone walking in the door. I'll sometimes do a net and just see if we find the answer of what it may be. But it is just throwing a net into the sea and hoping you catch the right thing. And I think that's a really hard answer because we all know Mito isn't on most of those panels. So there's not a way for families later to always figure out exactly what happened. And it is frustrating.
Isabel, I want to come back to you on this. So you had a sibling who had a mitochondrial disease. What are your concerns about your future? Are you showing any symptoms or have you been tested?
No, I haven't. I'm a little confused about it. Honestly, I know that my mom was tested and was told that it was fine and that myself and my cousin on her side wouldn't pass it down, but that was also like 20 years ago. So I'm not sure if anything has changed.
So you have been able to trace it back to where it may have started?
Yeah, I believe that we were told that it was just a random mutation.
So, Dr. Hirano, what kind of testing would siblings want to have in order to find out where they are in their journey?
Yeah, so maybe I should preface that by saying we generally don't test children for genetic diseases if they're untreatable. If they're treatable, of course, there's a reason to do that. But if it's a child, it's really not wise to test the child, because there's nothing that will change, and it creates a lot of anxiety and guilt in the family. So maybe Devin can embellish on this, but I think it's really something that we generally don't do in young children unless there's a treatment. But maybe Devin, you want to expound on that point?
I mean, the way I usually try to explain it to families is, if it's not going to change what we do, if it's not going to change management or treatment, let's let them decide when they're older. So instead of like, why not to do it, I say, this is why I like waiting. Like, let the adult decide if it's something that can wait, so that they can make an informed decision instead of assuming that they think the same way that their parents will in 20 years, which we have no idea. And so I try to, instead of why to do it or not do it, I say, let's try to do it for agency. And a lot of families can understand that reason when you tell it to them.
One of the great things about this webcast is we are global, so we get questions from around the world, and we have one from Belarus. They do not have mitochondrial disease specialists, and they only do blood work. So the patient is asking, does it make sense in their case to do blood work or find a laboratory that does buccal analysis? And what kind of workup would they need to confirm or rule out a specific mutation? And what other research would need to be done in their case? So Dr. Hirano, that's quite a lot, but is there any way you can help?
Okay, so again, it's this division between Mendelian and X-linked diseases versus mitochondrial DNA diseases. If it's, it looks like it's a disease from the nuclear DNA, it doesn't matter whether you test blood, buccal swab, saliva, whatever the tissue is, the nuclear DNA should be the same. But it makes a big difference if you're looking for a mitochondrial DNA mutation, because we know that the level of the mitochondrial DNA mutations can be lower or even undetectable in blood. And so we often prefer to sequence buccal swab or even urine sediment, and we're more likely to detect the mitochondrial DNA mutation in those tissues. So it does make a difference if it's a mitochondrial DNA mutation.
Okay, and another question on similar lines. They're asking about those of us who had the disease before genetic testing. So they had a daughter with Lee's who passed away in 1985 at age 10 months. And since they don't know the exact defect, it would be very expensive for them to test their other children. So they're asking, do you have any other suggestions when you don't know the exact cause?
Well, there are a couple of ways of approaching it. If there was any tissue from that child who passed away, maybe they had a muscle biopsy, that the tissue may still be available for genetic testing. And obviously the technology is much more robust now, and we can find mutations much more readily than we could in 1985. So yeah, we could, if there's any chance of retrieving some tissue that was stored in somebody's freezer in a hospital, that would be the most direct way to try to answer that question. But one could also do genetic testing of the parents and see if they are carriers of mutations that are known to cause Lee syndrome. If the mom carries a mitochondrial DNA mutation that's known to cause Lee syndrome, that could be an explanation. If the mom and dad each carries a mutation in, let's say, NDUSF4, which is a well-known cause of Lee syndrome, or SIRF1, then we could infer that the child probably had a nuclear autosomal recessive nuclear gene defect.
Yeah, she's going on to say that they did have fibroblasts saved, but they were discarded without their knowledge.
Oh, that's a shame, but so if the parents are willing, they theoretically could be tested to see if they're carriers and infer whether they, what the child had.
So Devin, I want to ask you this question. So, as you care for an adult child, and you're a parent, and you begin to age, what are some of the things you think about as your parents age, and with the prospect that they aren't going to be here forever? How do you as a sibling plan out the care for another sibling once mom and dad are gone, especially if they're their primary caregivers?
Yeah, I mean, I think it's a different answer for every family. I think for me, I've always known that even just working as a genetic counselor, it might not be something I can do for as long as other people till the age of retirement as Mito gets worse. So I did pick a field that I can do from home. So right now I do telemed. And so that is easier for energy. And I think for me, I've been trying to be smarter in terms of money and finances too, because I want to be as independent financially as possible, so that if I don't work as long as there's other things down the line, I have more preparation, or I'm in a better place to deal with that. That does come with a lot of privilege to be able to say that. Not everyone has a choice in that matter. But my family has always been really open about that stuff. So every time that my parents would redo their living wills and stuff, I was brought into the conversation. I was always a part of it, even when I was in college. Like, hey, which family friend do you think would be best if there was a plane crash tomorrow? And like, who would you feel comfortable talking with too, to help with all of that? And so I don't know if every family can say that that dynamic would work for them, but for my family, we've always been really open and honest about it. And I think it's helped, because it wasn't a sudden new thought for me at ever. It was something that was always on the table. And for me, that's also part of why I'm actually moving home in a couple of weeks. I like my brother, but I also don't want to be one of those people that in 20 years looks back and goes, oh, wait, I lost touch with them. And now I have to move home to help arrange medical care and stuff for them. So I'd prefer to keep that good relationship. Not that we all shouldn't do that with our siblings anyways, but I think for me, I have that added thought of, yeah, let's keep that good relationship good, so that when it does come down to hard decisions and conversations, you're not doing that with someone that you've mostly only seen at holidays for 20 years, which sadly is what happens to a lot of adults as we all move around the country. So for my family, that's how we kind of approach that.
Isabel, we know you are in medical school. So one of the questions that's coming in is, do you plan to work with people who have mitochondrial disease? Is that something that you're interested in?
Yeah, I'm going into pediatrics, so I would really like to work with kids who have disabilities. I'm not sure if I'll specifically work with kids that have mitochondrial disease, but I think that would be really rewarding.
Well, I want to stay with you, because this is a tough question, because unless people are in your shoes, it's hard to imagine. But some siblings tell us that after a brother or a sister passes from mitochondrial disease, that they have guilt. And even if they're affected, and I just don't know how you cope with that feeling. So is that something that you can help people who may be experiencing that right now?
I can't say that I've ever felt guilt about him passing away, so I'm not sure if I can answer that very well.
No, that's fine. It's just a feeling that some siblings have expressed to us that they have experienced. Devin, have you ever heard of this situation?
Yeah, I actually was doing an LHON talk a couple weeks ago with a great group of, it's all moms, so all women with it. And it was essentially that survivor's guilt that a lot of families go through. Even the moms would have it who passed it down, because they may never showed symptoms, but then their child did. And so I think, I mean, good news, it's a kind of universal thing for a lot of people feel survivor's guilt for medical reasons, for life, for so many different things that can happen. So I think there are, that's why I say luckily, a lot of good resources about survivor's guilt, but I'd say the best resource is talking about it. because just on that call, it was, I don't even know how many moms, maybe 50. And the second one person admitted it, you could watch everybody take a deep breath because they felt seen. And I think that's why people are drawn to the UMDF. You feel seen when you meet other families who've been through it. And I think we need to continue to make sure we include the siblings in that environment so that they can talk to each other and share those emotions.
Well, National Siblings Day is coming up April 10th, which is Saturday. So
Perfect excuse.
happy Siblings Day to everyone. If we did not get to your question tonight, and I know that a number of questions, Dr. Hirano and Devin, I know you answered a number of questions while we were online here. And if you want to go back and take a look at those, you can. But if we didn't get to your question, we will try to answer as many offline as we can. I'd like to thank my colleagues, Kara Strickmatter and Margaret Moore, whom many of you know. They continue to hang out in the background over there, making sure these websites have the webcasts happen for our patient families. For our panel, thank you all so much for your time on this edition of Ask the Mito Doc. Also want to thank our patient families for submitting some very fantastic questions. And as a reminder, our next Ask the Mito Doc comes your way May 11th at 7:30 East. We are going to be discussing drug development for mitochondrial disease, and we hope you will be able to be with us. So until then, stay healthy and stay safe.